Welcome to our cutting-edge online point-of-care ultrasound fellowship program. We are excited to invite you to this pioneering fellowship designed to empower healthcare professionals with advanced skills in acute care ultrasound. As a participant, you join a diverse global community committed to transforming patient care through innovative ultrasound practices in critical and emergency settings. Our comprehensive fellowship is meticulously structured into 2 immersive modules, each spanning 24 weeks. Whether you're just beginning your ultrasound journey or you're a senior clinician refining your expertise, this program is tailored for you. Our curriculum bridges the gap between theory and practice, providing an evidence-based, clinically relevant approach to ultrasound education. You'll explore critical applications, including shock volume assessment, cardiac function, and sonoanatomy, lung normality and abnormality pathology, several acute care procedural guidance, several real-life practical case scenarios, and much more. We understand the demands of your profession, which is why our fellowship offers unmatched flexibility. All interactive sessions are recorded and available on a user-friendly learning platform, allowing you to revisit key insights anytime, anywhere. Through expert-led lectures, real-world case discussions, and journal clubs, you'll gain a profound understanding of ultrasound applications, backed by the latest evidence. Our esteemed faculty consists of renowned experts dedicated to guiding and mentoring you throughout your journey. With their support, you'll enhance your skills and stay at the forefront of ultrasound innovation. By the end of this fellowship, you won't just master ultrasound techniques, you'll become part of a global network of like-minded professionals, fostering collaborations, knowledge exchange, and continuous learning in acute care ultrasound.
Thank you very much for everyone who's joining us today for this webinar, which is part of our POCUS in acute care settings advanced ER module. We are now approaching the end of the program, and this is the last live webinar we have for the program, and I hope you enjoyed the previous 19 week of advanced materials that was handled by a well-known expert who tried their best to give you their experiences and knowledge, and I'm sure you're reaching the landing page or the last step or steps in this advanced module. As I said, this will be the last live webinar, and we're very glad to have Dr. Ahmed Salman, Dr. Bushra, Dr. Amjad, Dr. Omar, who is going to give us in a scenario like their continued experience in the point of care ultrasound in ER live experiences. I have the pleasure to co-moderate with my friend Dr. Haitham Khalifa and Dr. Wissam Ibrahim as well. Let me just give you some of the logistics that very important to remind everyone that, as I said several times before, the live webinar was created for the fellows to meet the faculties, to ask their own questions about the previous 4 weeks, to bring their cases. I'm talking about the fellows, and if they don't, we bring them our cases, and that's what we're gonna do today. The faculty will share with you their real life cases. Let me remind you with the remaining steps in this program. You're gonna be left with week number 21. It's gonna start next Wednesday, 26th of August. Week number 22 will be the week after, September 2. And then September 9 will be week number 23. And then you're going to all set the final or exit exam that's supposed to be on 16th of September. And that's why we need to finish the exam before 26th of September, which is the date for the ceremony graduation of the WICCEM. The exam will be a 50 multiple choice questions with best answers, and the pass mark, as we did in the common pathway, will be 60%. So every candidate to pass the exam should have 60% of these questions correctly answered. Once you decide to choose one day of the week that start on 19th until the 23rd, 16th of September will start and will finish 23rd of September, a week for everyone to choose any day, any time, any hour, to sit in front of a computer and then to click on the exam. 50 questions, you have to answer them on the same setting. You're gonna have 90 minutes to finish the whole exam. Again, you have to pass with a 60% mark. If not, you're gonna have another chance with a different exam within the same week. So we would like to suggest you guys to start as the week start on 16th and use any convenient time for you, day or night, 24/7 for a week, because you're gonna have 1 to 2 chances to pass the exam, to be graduated and awarded the diploma. As I mentioned, the ceremony, which is going to be online, everyone has to celebrate. You can, there is a very interesting program that people are working on now for the ceremony, and I'm sure you're going to enjoy this with your family, with your beloved. You can invite anyone to attend online the ceremony. By here, I thank you for this introduction, and I should give the mic to Dr. Haitham Khalifa to start the program of today. And you all enjoy. If you have any question, you know how to reach us, me, Dr. Wissam Ibrahim, Dr. Haitham Khalifa. We have our own WhatsApp group. You can just text us. Thank you very much, Dr. Haitham. The floor is yours.
Thank you, Dr. Ashraf, for leading us through this one-year diploma. Now we are coming to the end of our fellowship. Today is a very interesting day, talking about different topics, musculoskeletal, soft tissue, neck ultrasound, and also Dr. Bushra is one of our students in this fellowship. She will give us a case presentation. We will start with Dr. Ahmed Salman. He is one of our great professional instructors. He's a consultant of anesthesia, pain management, ICU from Cairo University, and now he is the head of ICU unit in Iraq at Thaqalan Cancer Hospital. He is also the founder of the MSK Nerve Block chapter with Sun School. So, Dr. Ahmed, the floor is yours.
Thank you very much. I hope you can you hear me now, and I hope that you can see my my background.
Yes.
Okay.
Clear.
So let's start immediately with our presentation, as I have not one case, just one case in details, and two just teasing cases for our colleagues, and opening a discussion. I hope that I will finish in my 15 minutes, inshallah. So I will discuss the chapter or the part of using ultrasound in musculoskeletal and regional anesthesia. And in the beginning, I want to remind you that what is the importance of this, and I'm mentioning this although I'm sure that every one of you knows the importance of it, but I'm just highlighting it again because I will tell you at the last case why that ultrasound is a very, very important tool for diagnosis and management of cases in the ICU and in the emergency regarding the musculoskeletal and regarding the pain in the limbs and in the body that can be an alternative for a systemic drugs that is unsafe to be used. So remember, ultrasound is a technique. Musculoskeletal and regional anesthesia are one of the steps that you want to think and to put it in your consideration in emergency and ICU. Our case today is an 80 years old female. She was admitted in a hospital for control of her medical problems. She is diabetic, hypertensive, atrial fibrillation, ischemic heart disease. She has a urinary tract infection, impaired kidney functions. As well as that have been invited for this part, she has a severe unilateral lower limb pain on the right side with a history of multiple levels lumbar disc prolapse. So they call me as a pain consultant, anesthesia, ICU, and pain consultant for management of the pain of this case because she has a severe pain that she cannot move from the bed. She has severe even agony. She cannot sleep. So they consult me: is this patient is a candidate for medical, although she is taking too much drugs and medications, or we can do an interventional pain procedure so we can solve this problem without giving more and more medication. And we know that this age with all these medical problems. Then when I came to the patient, I did an assessment for clinical data. The patient was fully conscious. She was speaking, oriented, time, place, and person, speaking very well. But the only problem that she cannot move from the bed because she has severe pain. Her heart rate was 70 per minute. It's irregular. She has atrial fibrillation. Her blood pressure was 110/75. The blood pressure was controlled. There is no signs of infection, and the fever was, temperature was normal. She was bedridden. But here I realized something, that the patient has her left leg slightly externally rotated. Okay. And she has a severe pain in her, right leg and in her whole right leg. Okay. And here I started to think, and I will ask and open the question, the floor. What do you think? What is my next step for management of this pain? What do you think? I hope it's a discussion. So anyone has an answer? What is the next step? What I will do now?
So they can write on the chat or the Q&A section if anyone wish to interact.
Yes, you can write in the Q&A, and I will tell Dr. Ahmed about what's written, okay?
Okay, so I will continue. Yes?
Yeah.
And here is what is the next step. I will do analysis of the
Hip
pain.
X-ray, someone's saying hip X-ray.
Okay, hip X-ray, it's a good question, a good answer. And I will give you in the next step. I'm looking actually for, before hip X-ray, for the history. I will ask for the history and and as you said. So for the history, the patient has been consulted for. The patient has disc prolapse and pain, and usually the pain coming from the disc prolapse is a neuropathic pain in nature. So it should have some symptoms like numbness, electric needling, burning sensation or something. But for this patient, the pain has no numbness, no any neuropathic in symptoms, and it was a localized hip joint pain. Whole limb position was slightly externally rotated, and she cannot move the hip joint. So one of my colleagues said already, hip X-ray, please do X-ray. The patient 2 days ago, she underwent a CT for hip and an orthopedic consultation, and it was normal CT scan for the right hip and the left hip, by the way. And the orthopedic consultation, he is the one who said that please bring a pain physician for the low back pain. But again, even though if there is a CT looks like normal, if orthopedic consultation have looked to the patient and said that, this doesn't exclude what you all think. And my colleague who said ask for X-ray doesn't exclude it. So what is my next step? As usual, I decided to do a hip ultrasound. Okay.
Yes, Dr. Aisha recommended also if we can do lower limb Doppler ultrasounds.
Exactly, this is a very good option. Doppler, and the Doppler ultrasound was done. Maybe I didn't write it down, but it was normal hip, normal lower limb ultrasound, normal lower limb Doppler. I mean, and no any signs of DVT or something. So when I did, as you can see, when I did the ultrasound for the hip joint, and it's a very easy way to see the head, the neck, and the neck of the femur. You just put, as you can see here, you just put your ultrasound oblique on it. So you can see here's the head, then it's the neck of the femur, and this is the iliopsoas above. It's the same. I found this, what you can see here. Let me put the marker or the laser pointer here. I found this, there is discontinuity of the bone matrix here in the neck of the femur. And at the same side, you can see there is an extension or widening. So when we use the ultrasound, as you know all, and I know that you have been now better than me in ultrasound after 1 year of our diploma, that you can see that you are either looking for a problem or the effect of the problem. And here I'm looking for both. There is a problem, there is no intact bone here. At the same side, there is an effect of the problem, there is an effusion among here. And by the way, before this, once I touched the patient by the ultrasound, it was severely localized pain on the neck exactly. What I cannot actually have an answer and justification for is why 2 days ago the CT of the hip joint and the orthopedic consultation didn't diagnose or find it. And I saw the CT by myself, and it was actually, there is nothing in the CT. And this is what one of the things that called occult or hidden fracture neck that can be diagnosed by ultrasound better than the CT. So here, what is the best way to manage the pain? Again, I will ask the floor, medical treatment or nerve block. And remember, if you have the answer is not to choose one. I need your justification about one. So if you choose the medical treatment, why? If you choose the nerve block, why? If you don't want to choose the nerve block, why? If you don't want to choose the medical treatment, why? I will give you just 30 seconds if someone wants to write something.
You can share your answer in Q&A box, and I will inform Dr. Ahmed. Both of them useful. Okay, this is Dr. Aisha from Turkey.
Okay, let me open for you some consideration, and let me have your answers after that. General consideration. What do you think about patient?
Yeah, okay, nerve block till further orthopedic action. This is from Dr. Nabil.
Okay, so now I will ask you not few questions. I raise up some problems or some consideration, and I want you answer the same question after. So for this patient, what about the patient general condition? What do you think? The patient is receiving multiple medications, a huge kind of medications, and you know that the patient has an impaired kidney function, impaired organ functions, okay? But on the same side, she is AF, means mostly, and bedridden. So she is taking anticoagulant mostly. And to be honest, with a bedridden so which kind of anticoagulant she is receiving, therapeutic or prophylactic? And can I use the nerve block with this situation or not? Or I prefer to use it because any pain control for the bone, I need a huge doses. Either opioid with this patient general condition, old age, will affect the conscious level and maybe affect her, conscious and the breathing, but the non-steroidals and the other options also will affect the organ function. So what do you think about your medication you will give if you decide to take the medical treatment? Is it will interact with other medication or not? Okay, so again, can I put a needle for the patient on anticoagulant, or maybe the CBC, the platelet is affected? So what do you think about the bleeding profile of the patient? Is it only platelet function, or you need or anticoagulant, or you need also to consider that the patient maybe has a liver function problem and coagulation problem, so the BTU, BCINR, ABTT, all these things? What do you think about the duration of pain management if I decided to do a nerve block? So to what extent it will take to work, and to what duration it will stay? And on the other hand, but the medical treatment, I will keep giving this for the patient. And finally, is this patient is a cooperative patient, so she can tolerate taking a medication through oral or other route? Or on the other side, she will be able to tolerate that I'm doing a regional block, so maybe I will put ultrasound, I put a needle awake with some local infiltration. Again, there is no true and false. There is no, but still, you have to think about, we can use here the regional anesthesia. And finally, as you know, my presentation and my discussion is about musculoskeletal and regional anesthesia. So I you know my choice. It was regional anesthesia. And here I will ask you, if you have a patient like this with a femur neck fracture, do you have one of the safe blocks that you can do for pain? I will give you 30 seconds if someone can choose one block.
Dr. Karim selected fascia iliaca block.
Thank you, Dr. Karima. It's a very good option. But again, here, can I ask you which type of it? I'm sorry, but this is another question because it's a very important question. Which type of fascia iliaca? I will give you the two answers and I want you to choose one. So it's suprainguinal fascia iliaca or subinguinal fascia iliaca block. Which one you will choose? And why? Any answer, Dr. Haitham?
No till now.
So the safe one is the fascia iliaca subinguinal fascia iliaca block, not the suprainguinal fascia iliaca block. And this is it was my choice actually. I did the subinguinal fascia iliaca block. As you can see, I will not speak about technical how it will done, but why subinguinal? Because suprainguinal is a safety profile. If the patient has a bleeding tendency, is more dangerous than subinguinal. And why is that? Because when you do a block for a patient and you are considering that the patient either on anticoagulant or the patient bleeding tendency is high, so you have to choose one that is vascular distance, it's away from the vessels. It's a compressor to choose one that has a clinical consensus from different societies that it's allowed to be used with a patient with higher bleeding tendency than the other. Like the subinguinal fascia iliaca block is accredited from the Regional Anesthesia and Pain Medicine of American Society, Canadian Anesthesiologist Society. All of these accept that the use of subinguinal fascia iliaca as pain control even with a patient with a higher bleeding tendency. For our patient, alhamdulillah, we did fascia iliaca block subinguinal. Within, the patient underwent hip surgery after 2 days, and she was controlled of pain for this 48 hours. And I know that you have a lot of questions. So the fascia iliaca can work up to 2 days. This is a huge discussion. I will say something or some of it in the next two discussing rapid cases. So case number 2, you have a patient, which is this one was the patient, 13 years old, presented to the emergency department. I was in South Sudan, by the way, in Akobo, some kind far away from everyone. And I was in the emergency department, presented to me a child, 13 years old, a boy with a snake bite in his right little finger. And he presented vitally normal, fully conscious, has a mild to moderate edema in his little finger, but the most important thing that he was having severe distracting pain. He was jumping from the pain, of the snake bite in his little finger. So consultation for pain management. What do you think? What is not only pain management, actually, there I was doing everything. So consultation for managing of this case. What do you think? I think I have a lot of emergency doctors that know how to deal with the snake bites. I think so. Yes. So what do you think? And by the way, teasing why, I want to show you, this is the antivenom. We have the antivenom. So if someone didn't work with the antivenom, didn't use the antivenom before for the snake bites, this is one of the antivenom. Actually, it's a very expensive one. I used it multiple times there when I was in South Sudan. Just to keep it in your mind, it has a specific indication. It has a specific way of delivering for the patient, and it's highly allergen. So take care when you are using. This is out of the scope, but just because not everyone can see this antivenom everywhere. So go back here. The option was, what do you think? So if I decide to do a block for this patient, which block? And which local anesthetic I will use? What is the dose? What is the concentration? What is the volume of local anesthetic? Should I add something to the local anesthetic or not? Should I give the patient some recommendation when I do him the block? All these you have to answer before you decide to do the block. And you always, I tell my attendee and my my colleagues and my trainee that, remember, the good doctor is to know when not to do something, when it's contraindicated and dangerous to do. So which kind of block? I will answer this question rapidly because maybe I'm exceeding my time. The first thing, that the block that had minimal effect systematically or on the limb. So for example, little finger, as you can see, little finger, I can do isolated ulnar block at the wrist. I can do isolated ulnar block because little finger supplied by ulnar. At the elbow, I can do isolated triple nerve block at the wrist or at the elbow. I can do axillary block, supraclav, infraclav, or infraclav, supraclav, or even supraclav or infraclav. So all these blocks are considered. But remember, when you do a block, especially for pain control, use the minimal one, because the more you go higher, the more you block nerves, the more you make the patient difficulty to move. And this is take you to the last question, which is, what is the recommendation? Tell the patient that maybe your feeling in your hand will not be that much, and maybe you will feel weakness in your hand. So it's a dangerous. So if he's going home or using the hand, maybe he will injure himself without feeling. And then which local anesthetic? Remember to use the longer duration better than the shorter duration. The shorter we use for the surgeries, not for the post-operative pain. Which dose, which concentration, which volume? I'm just highlighting here. This will take a lot of time to explain, but I want you to know that when you use local anesthetic, there is what's called dose to affect the block. That's what's called concentration that will affect the block, and there is the volume which will affect the block. All these will affect the block. So you need to modify the three for the best result, least toxicity. And finally, which additive you add on the local anesthetic so it will work longer duration, or it help you to use less dose and less concentration, less volume, so less toxicity. Antivenom, I just discussed, and let me just show you, because a lot of my colleagues usually they know about the region and nerve block, but they doesn't know the effect, especially if they are not in the OR. So let me just, I hope this will work. Let me have here. Let me remove this. Yes.
We have 2 minutes of Ahmed.
Yes.
This is the infraclavicular. This is the axillary artery pulsating. It's a living beside. Okay. And we are doing the rapid now. So I have to bring the clavicle. You can see down the edge. The clavicle is coming from the edge. And now you can see my needle is coming. Needle is coming from below the clavicle. This approach is very nice because it's make the alignment.
Can you see it? Yes.
So you can see my needle now is coming below the clavicle, going from the infraclav with a clean view. Wait, I'm just below the artery now. You can see with a straight view, not with the acute angle.
Here is the needle. I'm doing the block.
Nothing. Go back. You can see.
And I want to
here, just.
I want to tell you that after this block, this is the procedure. You can see they open all the patient hand and arm
Yeah, this is just.
And the patient is fully awake. And the patient is fully awake, speaking, talking, although they are doing all the procedure in hand. So the regional anesthesia is an alternative, even for general anesthesia, in an extensive surgery. Like this one has a brachial plexus injury, and they are doing anastomosis, opening all the arm, and you can use the regional anesthesia safely and effectively. Okay, the last case, it's just a teasing case. Patient with 26 years old female presented after a fall from a bicycle with a fracture of radius and ulna on the right arm. Closed the fracture. The decision was for waiting on a cast for 2 days to edema to subside. Pain was severe and not controlled by medical treatment. And this case was in one of the very, developed country. I will not say developing country, developed country. And how they control the pain in their hospital. Unfortunately, they put the patient on anesthesia, muscle relaxant, in the ICU, mechanically ventilated for 2 days to control this pain until the time of the surgery. Can you imagine that patient has been on a mechanical ventilation 48 hours just for pain control of an arm pain? So again, I'm raising up, please, my colleagues, please remember that in the ICU, remember in the emergency, you have another option for pain control, which is using of ultrasound for regional anesthesia. You have another option for diagnosis, not only X-ray, not only CT. Ultrasound can help you in musculoskeletal diagnosis, in the fracture detection, in the soft tissue affection like tendo-Achilles fracture, in the joint and bursa effusion, in the foreign body detection in some places, and in vascular and nerve integrity diagnosis of compartment syndrome. Here, another case of a huge hematoma that had been aspirated using the ultrasound guided in the musculoskeletal, and the advantage is speed, portable, easy, dynamic, and it's a guided procedure using the ultrasound. Take home message, remember, rapid triage diagnosis, musculoskeletal now in POCUS has a very important diagnostic feature. It's a dynamic, it's a procedure accuracy, very accurate, and you can use it for regional anesthesia, and it's a radiational free. Thank you very much for this opportunity, and sorry for taking more than my time.
Thank you, Dr. Ahmed, for this comprehensive presentation. I can take only one question. Someone is asking if we make a block at the same site of a snake bite. Is there any possible complication or overlapping of progression of the disease or something like this?
Okay, so I think this question is coming because usually the blocks in using of local anesthetic as increasing, produce vasodilatation, increasing the blood supply for this place. So is it possible that when I increase the blood supply of this place that I increase the absorption of the venom? This is the first thing. The second thing is the increase of the blood supply will increase the edema or not? This is two questions to answer. And by the guidelines and by the guidelines and recommendation that there is no any relation between using of regional anesthesia and increase the absorption of the antivenom. Now, because also mostly the patient is coming or we control the pain after managing the acute state, which is starting from 1 to 2 or 3 hours. I know it can extend until 12 hours, but after 2 or 3 hours, it's manageable now. So we usually use systemic till 2 to 3 hours. The patient passed the severe critical time, and we diagnose that this type of venom, either it's neurotoxic or cytotoxic, or it's a histotoxic. And then after we diagnose, we can use it. It's safely, effectively, and I didn't see any complication, and it's written in the recommendations.
Thank you, Dr. Ahmed. And now Dr. Wissam will introduce our next speaker. Dr. Wissam.
Thank you so much, Dr. Haitham. Thank you for this interesting lecture, Dr. Ahmed Salman. Now I have the honor to present Dr. Bushra Beldek. It is one of our senior candidates with some knowledge of ultrasound even before taking the course. She worked as associate professor in Department of Emergency Medicine, Karabakh University, Faculty of Medicine in Turkey. Now the floor is you, Dr. Bushra.
Thank you so much. I will share my screen. I hope you can see this.
Yes, we hear it you now.
Okay, sorry. So thank you again, and it is my pleasure to be here with you presenting a case. I will present a case that I had recently. 70 years old patient was admitted to emergency department with poor general condition. According to his next of kin, he had right flank pain and nausea for the 5 days. And also he had intermittent fever at home. And also he was anuric since the previous day. And according to his past medical history, he had hypertension, atrial fibrillation, coronary artery disease with PCI. And also he had abdominal surgery for small bowel obstruction previously. He was hypotensive and also tachycardic. There wasn't any obvious respiratory problem, but he was slightly feverish. In his rapid examination, he was lethargic, and also he was dehydrated by appearance, and also his capillary refill time was prolonged. And he mentioned that he had suprapubic tenderness, and also you'll see here because of the anorrhea problem, we actually inserted a catheter, and the moment we inserted the catheter, we saw this pyuric urine. So what would be your immediate priority? I'm not able to hear or see the Q&A. Is there any answer? So, okay, I will continue. And
Dr. Aisha, select B.
Dr. Aisha,
okay, cool. So we choose the B option as well, and rapid shock assessment and resuscitation. But we had a question: which part should have been using first and why? For the assessment of rapid shock, and of course, while we are doing resuscitation, we would use this the POCUS part. So since the patient was in shock, we decided to determine the type of shock first. As you can see here, the first view we obtained was the cardiac view. And due to poor echogenicity, the subploid view was the only view we could actually obtain. But I believe it was sufficient to draw some conclusions. I will show again. The patient had biatrial enlargement due to atrial fibrillation with no right ventricle enlargement. The ejection fraction was approximately 40% based on eyeballing, but there wasn't any enlarged left ventricle. See again. And we assessed IVC then. This is IVC, which showed more than 50% collapse. And based on these images, these videos, and also the patient's clinical presentation, we decided to focus on sepsis as the likely cause of shock. And because of the patient's pyuria and also this anuric state before, we examined the bladder here. As you can see in this first video, the bladder was filled with echogenic material. At the bottom of the bladder, in the second one, you can also notice a thin anechoic line. That's how we actually notice the difference between the normal urine and this heavily material. In addition, there were 2 stones with acoustic, posterior acoustic shadowing. One of them is here, the second one is here. In the second video, you can see the catheter balloon. You can understand the difference between stones and the catheter balloon. and the enlarged prostate. See again, just a slightly enlarged prostate, but it is big. We had actually clamped the catheter before performing the scan. That's why you can see this big bladder. The third part was kidneys. POCUS revealed bilateral hydronephrosis, graded as grade 2 on both sides. We roughly can say that moderate, actually. Unfortunately, we were unable to obtain good images of the urinary tract because of the poor echogenicity, but you can actually see the hydronephrosis clearly. And also, you can notice that there was complex free intra-abdominal fluid with internal subtations. Those are actually subtations from here to here. So until now, what did we see? We saw two bladder stones. One of them was 3 centimeter and the other one was 1 centimeter. Actually, we saw markedly echogenic urine with suspended debris. Also, the prostate was enlarged and he had bilateral moderate hydronephrosis. Also, we saw complex free intra-abdominal fluid with internal subtations. And we noticed that patient had the signs of volume depletion. Based on the case and the POCUS findings, what would be your leading diagnosis? Perennial acute kidney injury from dehydration alone, or urosepsis with obstructive uropathy, or maybe just intra-abdominal hemorrhage, or acute decompensated heart failure.
Dr. Aisha, Dr. Yusra, Dr. Ammar, answer B.
Okay, cool. It wasn't so hard to answer, I know, but it is the case. According to our diagnosis, we initiate the immediate sepsis management with IV fluid resuscitation. And of course, it was guided by a repeated clinical and POCUS assessment. We also initiated empiric broad spectrum antibiotics. And it was obstructed infected urinary system pathology, and it was a source control problem. So we consulted the urology department for advanced treatment. And also we draw some blood culture and urine culture. And if you want to know, it was the ESBL producing Klebsiella pneumonia. So for take-home messages, POCUS as a powerful bedside tool for the rapid assessment of critically ill patients, especially in undifferentiated shock, just like our patients. And POCUS can go beyond identifying the type of shock, or just like our patient, it can help uncover the underlying cause and also identify time-critical pathology. And last one is integrating POCUS findings with the clinical picture can accelerate diagnosis, guide immediate management, and can facilitate timely resource control. And that was our patient. Thank you for your time.
Thank you so much, Dr. Pusher, for this nice case introduction. I think for questions, till now, I don't have any question in Q&A.
Is
Okay, I think no pressure right now. Thank you so much again. And the floor is you, Dr. Haitham Khalifa, to introduce your coming guest. Thank you.
Thank you, Dr. Boscha, for this interesting case and for your contribution. Dr. Amjad Mapoor is an emergency specialist working in Lebanon Haikal Hostel, and he is one of our instructors. He is going to deliver a presentation about the neck ultrasound, one of some silent killers in the emergency department, some infections and other pathologies. So, Dr. Amjad, the floor is yours.
Thank you, Dr. Haitham. Thank you, Dr. Wissam. Hello, everybody. So happy to be with you today. Our presentation today will be a summary for the material of the week concerning the neck ultrasound. Wishing that the material was helpful and clear for everybody. Today, we choose a case from the literature to highlight the importance of neck ultrasound in changing our decision in the emergency department, to show how it can influence what next action we can do for the best of the patients. So, learning objectives. First, knowing the utility of POCUS in the rapid assessment of airway and also other structures in the neck region, knowing the limitations, landmark, and the landmark of cricothyroidotomy, identify intraluminal abnormalities via airway ultrasound, and to integrate POCUS in high-risk airway decision making. Our case will be a 56 years old male presented to the emergency department. History goes back to 6 months of hoarseness, weight loss, and dysphagia. Acutely, patient presented with inspiratory stridor, exertional dyspnea, and this was after an upper respiratory tract infection. Vital signs: blood pressure was stable, patient is tachycardic, and saturation is low, on non-rebreather face mask, and on physical exam, patient has a hoarse voice, non-drooling, trachea is midline, and no visible mass externally. Few times patients start to fail to ventilate, and multiple attempt to intubate was failed, with an evidence of internally distorted anatomy on direct laryngoscopy and video laryngoscopy. So at this time, stridor is a warning, and we should take a critical decision. And usually, when intubation failed with multiple attempts by a specialist, the next step will be a crico done in the emergency settings. But before doing the crico, a small view of the upper airway was done, showing, as you can see in the image B, the normal longitudinal view of the airway, showing the cricothyroid membrane with the air mucosa interface with the normal anatomy. And in our patients, you can see clearly distorted anatomy of the cricothyroid membrane and an evidence of mass in the deeper tissue. And this view is a transverse view for the same place that show clearly the normal image and the distorted anatomy and the presence of mass in this case. Naturally, when we see this mass, the decision will change, since the crico in this case will be a messy situation, and definitely it will fail. So using the direct laryngoscopy, you can see a mass distorting all the area and obstructing the airway, and the decision was made to do tracheostomy by a specialist over the cricothyroidotomy. As you can see, POCUS has showed a mass disturbing the membrane and making the crico unsafe. Flexible laryngoscopy and CT done after the tracheostomy showed a laryngeal carcinoma, and we'll show you the image after that. And in this case, the decision was changed from crico to tracheostomy. This is the CT scan after the tracheostomy was done. Clearly, you can see a mass obstructing the airway, and we'll show you the dangerous decision of crico in this case. So first, a small view in the upper airway has changed the whole decision to intubate and to ventilate the patient. What else? What can we change else? Using neck ultrasound, you can see the vocal cord. And as you can see here, you can assess the movement of the vocal cord shown in this picture, a unilateral moving vocal cord with paralyzed contralateral vocal cord. And this will influence the decision of extubation and the decision of what will be or what can be the cause of upper airway obstruction. And also you can assess all the tracheal ring, and you can see the tube or confirm the ET tube placement and the cuff position. What else? At the vascular level, you can assess the internal jugular vein and the carotid for multiple purposes. Placement, line placement, assessment for DVT, upper extremity DVT. You can also assess the central venous pressure using the jugular venous pressure, and also you can assess the carotid for any stenosis in cases of acute CVA, or if you heard any carotid growth on the stethoscope. And as you can see in this image, clearly there is a clot inside the internal jugular vein, okay, which is clearly viewed on the longitudinal view of the internal jugular. What else? Also, we can assess the thyroid. If there is any thyroid mass, you can assess the size, the presence of nodules, the form of these nodules, and what can be these nodules. Also, you can assess the in case of abscess, cellulitis, you can see any drainable collections in the soft tissue, and also cervical lymphadenopathy can be seen clearly by the ultrasound to know what is, or to put the next step in the management and the case. So the takeaway message, Streeter is a critical airway emergency. POCUS can change your decision in the next step, or in the critical next step, for ventilation and for intubation. Any neck mass, any hematomas, it can be seen clearly using POCUS. And then, as you can see in this case, tracheostomy was safer than blind cricothyroidotomy, which will be a messy situation in this case. Thank you. The references. If you have any questions, I will be happy to answer it. Dr. Haitham.
Thank you, Dr. Amjad, for this nice presentation. If there is any question in the neck ultrasound, please, you can write in Q&A. We will go to our last speaker with Dr. Wissam. Dr. Wissam, please, can you introduce Dr. Omar?
Yeah, thank you, Dr. Haitham. Thank you for this nice introduction and nice lecture. Thank you, Dr. Amjad. I think it's my pleasure to introduce Dr. Amar Jaradat, Assistant Professor of Emergency Medicine, Erbakan University, Faculty of Medicine, Department of Emergency Medicine, Konya, Turkey. The floor is you, Dr. Omar, with your nice lecture. Thank you.
Hello, everyone. It's my pleasure to be between all of you. Today, I'm going to discuss a case about soft tissue ultrasound, and I will be guiding you through this presentation. So let's start with our case. Well, our patient is a 50-year-old male with poorly controlled type 2 diabetes. He presented the ED with the left lower leg pain, redness, and swelling for over 48 hours. It was then that he scrubbed his leg on a metal pedal approximately 4 days ago. And what about vitals? The patient was slightly tachycardic, hypotensive, feverish. The other systemic examinations were unremarkable. However, we noticed an erythema over the tibia, which was warm to touch, but with no obvious fluctuance. However, the patient was in moderate to severe pain when you gently palpate the area. So there was a pain which is out of proportion in that area that alerted us. So let's move to the first interactive question. Based on the clinical picture, what is your most immediate concern and what is the best next bedside step? I'll wait for 30 seconds. No answers, Dr. Wissam or Haitham?
There is two
No.
answers.
Yeah.
Dr. Aisha and Dr. Nabil selected C.
Dr. Amal, please do also selecting C.
Great. So most of us, I think, is thinking about the big three soft tissue infections. Before I move to the rational, I would like to remind you that physical examination can be unreliable for differentiating simple cellulitis from deeper infections. So let's grab the probe and take a look at the superficial tissue of the patient first. First, we started the scan from the unaffected leg using the linear probe to establish a baseline normal soft tissue. Then we moved to scan the affected area using a lot of gel to avoid putting painful pressure on the skin. So take a look between those two views, two clips. You see here a normal tissue, and however, in the affected area, you see that that tissue is a little bit different from the normal one. So I will move to the next question. We place the probe on the most tender area of the patient's leg, and this is what we see. I'll play the video again. Look closely at our patient's POCUS. What is the predominant sonographic finding you see in this clip? I'll play it again.
Yes, we're still waiting for the answer.
Yes, I'm waiting for the answer for just 20 seconds.
Dr. Nabil, answer C.
Good. The correct answer is actually B, which is subcutaneous edema with slightly hyperechoic fat lobules. So let's move to the rationale of the question. Here you see two distinct figures. The first one is the normal soft tissue ultrasound. You see the soft tissue, the structures are well defined of the soft tissue. However, in the next one, you see here that structure of the soft tissue is now disrupted, and it is not that well defined. Also, it is a little bit more hyperechoic than the normal one. So this is the classical appearance of the cellulitis: the thickened hyperechoic subcutaneous tissue along with anechoic fluid appearance. Usually we encounter this appearance in early cellulitis. However, let's take a look on the second video, and I'll play it. Here you see anechoic fluid tracking the fat lobules. I'll play it again, with no organized fluid collection. It is known as cobblestone sign. You see that the fat lobules are now separated with fluid. This is also the appearance of cellulitis, but we encounter it in advanced or aggressive cellulitis. That was what our patient had until now. To remind you, for a very important thing in the soft tissue ultrasonography, always do not forget to check for abscess, because cellulitis and abscess often coexist. So we shouldn't forget to check for abscess. So look at this example. Once I play the video, the first second of the video, you see just a classical appearance of the cellulitis. However, once we swipe down the probe, you see here an anechoic or hypoechoic fluid with a posterior acoustic enhancement, which is a diagnostic for the evidence of abscess. By the way, our patient did not have abscess. Until now, we just have cellulitis. So let's move to the next question. This is the scan that I shared with you in the first question, the real ultrasound for our patient. So this scan appearance was highly characteristic of cellulitis without a clear drainable abscess evidence. As the treating physician and the POCUS user, what is the most appropriate next step that you should do to the patient? Any answers?
Just waiting for more answers.
Well, the correct answer is C. Ensure you assess the facial line for fluid or gas. While A,
and Dr. Hani answers. Okay.
great. While A and B are classical pitfalls after usually we encounter after the basic focus courses, D is incorrect because aspirating an inflamed fat has no diagnostic yield and may introduce the risk of infection. However, C is rational because while the patient has cellulitis on the surface, maybe the real enemy might be hiding just a few millimeters deeper. So let's look in the next slide what happened when I just continue swiping the probe downside the tibia. Here's the video. Look closely at our patient's POCUS video. What is the most alarming finding present here? I'll play it again. Any answers?
We have Dr. Nabil answer D.
Right. That's yes. The correct one was the subcutaneous gas or dirty shadowing.
Also, Dr. Aisha.
Right. Let's note the rational then. The fascia, which is a thin, bright, hyperechoic line that surrounds the muscles. And let's look to this figure. The presence of fluid tracking along the fascia is a red flag for necrotizing fasciitis. So here, this is the subfacial fluid, which is highly suggestive and should warn us for the presence of necrotizing fasciitis. Also, let's move to the second appearance. You see here the orange line is the demarcation line actually between the normal soft tissue and the tissue with necrotizing fasciitis. The yellow arrow actually indicates the appearance of hyperechogenic foci, which is the appearance of gas in the soft tissue. Also, I would notice you that the tissue here is unremarkable and it can't be defined when you compare it with this one. So, to avoid missing the evidence of necrotizing fasciitis, I would remind you with the staph mnemonic when evaluating soft tissue. The first, let's check the subcutaneous thickening. Also, the subcutaneous hyperechogeneity. The second, let's check about the evidence of the appearance of air, which is looks like hyperechoic foci, or this appearance also known as dirty shadowing or rain down artifact. Also, we should check about the evidence of facial fluid. All of those options are actually the remarkable signs of necrotizing fasciitis. Well, let me clear my drawings and go further. Also, in this video, you see a small hyperechogenic foci, like a white dots here. Those are the appearance of cancer, soft tissue, which is diagnostic for necrotizing fasciitis. So we should not miss them in our examination. So let's move the next question. As we have confirmed necrotizing fasciitis in our POCUS, what is our immediate clinical decision to this patient?
We have answer C from Dr. Nabil, Dr. Aisha, Dr. Balqis, Dr. Abdurrahman, Dr. Alan Carrion. Yeah, all of them answered C. Dr. Samar. Yeah,
That's correct.
Dr.
Well, let's go back to our case then. At the end, our patient was started on broad spectrum IV antibiotics. Surgical consultation was called immediately, and the patient was taken to the OR, where necrotizing fasciitis with facial necrosis was confirmed. The patient actually required multiple debridements and ICU admission for hemodynamic support. So I will go to the take-home message. The first thing, don't stop at the cobblestones. Finding cellulitis on ultrasound do not rule out deeper pathology. Always scan down for the evidence of necrotizing fasciitis and for the evidence of abscess. The second thing, remember the staph pneumonic, which is the subcutaneous thickening and subcutaneous hyperechogenicity, the appearance of air or dirty shadowing, and the presence of facial fluids, because they are the hallmarks of necrotizing fasciitis. And clinically, do not forget that time is tissue. Once you set the diagnosis of necrotizing fasciitis using the POCUS, do not delay for advanced imaging, especially in hemodynamically unstable patients. Thank you for listening. I'm ready for answers. Thank you.
Thank you so much, Dr. Omar, for this nice lecture. We are waiting a while for some more questions. If any candidate have a question. Okay, thank you again, and thank you all.
I have a question, Dr. Wissam, if you don't mind.
No,
Yeah, the question for Dr. Omar. First of all, I enjoyed the presentation because it's one of the common presentation to emergency department is to see cellulitis, and it's very, very essential and might be considered as life-saving, is to differentiate between the necrotizing fasciitis and cellulitis, and the degree of cellulitis also makes difference. So sometimes we see in the subcutaneous tissue threads of hyperechoic shadowing. How we can at bedside differentiate if this is gas or this is might be the tendon or anything else. So with the simple cellulitis without necrotizing fasciitis, how can, if you can give us tips for simplifying how we can differentiate between both based on the ultrasound or POCUS exam. Of course, everyone knows that clinically you feel the limp, you feel the crepitus or not, but sometimes it's very difficult to feel the crepitus. So any idea, Dr. Omar, to simplify it more, how to differentiate between simple cellulitis, let me say, or subcutaneous air to signify necrotizing fasciitis?
Well, actually, we lean on the artifacts of the ultrasound in distinguishing between these two diagnoses. Because the air in the subcutaneous tissue will generate a ring down artifact, or known as dirty shadowing, you will definitely lose the normal structure of the soft tissue. So once the air is there, there is no clearly defined structure regarding the soft tissue. This suggestive for the appearance of gas, which comes from the fascia or the tissue from deeper tissues like muscles. Also, if we can encounter, especially in early phases of necrotizing fasciitis, if we may encounter with the evidence of the subfacial fluid, it is also suggestive and can differentiate between the cellulitis and necrotizing fasciitis. So, however, necrotizing fasciitis starts with a cellulitis actually. So you will see in the subcutaneous tissue hyperechoic with undefined structure of the soft tissue, especially in the subcutaneous tissue. But below of it, once you find a subfacial fluid or the appearance of gas, which will limit us in distinguishing or define the clear structures of the normal soft tissue, this will shift our diagnosis from cellulitis to necrotizing fasciitis, which will also change the whole management of the patient. So we lean on especially on just an sonographic artifact. That's why this is the first lecture we give in the fellowships or also in the ultrasound courses.
So a kind request for everyone who is practicing the point of care ultrasound in acutely ill patients in emergency or anywhere, just practice it. So any case of cellulitis, put the probe on. You lose nothing. Vascular probe, and you see, put it on the most inflamed area. And as Dr. Omar said, move it away to the less inflamed and then move to the normal areas and see the difference between those different part of the normal and abnormal limb. Thank you again, Dr. Omar.
you, Dr. Ashraf. So in this session, we have like a 4-case scenario today with our eminent speaker, Dr. Amjad, Dr. Ahmed, Dr. Omar, and Dr. Poshra. Thank you.
I want to thank everybody, and for our colleagues, please, if you have any question during this next month, please share in the WhatsApp group. We have all the faculty with us in the group. Please prepare for the exam. You have only, I think, 1 month before the exam. It will be from different topics, practical exam and like case scenario based questions. So be well prepared. If there is any question, we will all here to help you under supervision of Dr. Ashraf and Dr. Wissam.
Thank you again, Dr. Haitham, and thank you, Dr. Wissam. Thanks, a special thank to Dr. Omar Jaradat, Dr. Bushra, Dr. Ahmed Salman, and who else?
Amjad.
And Dr. Amjad, yeah, and Dr. Amjad. Yeah, thank you very much. I personally enjoyed the whole presentations. Very, very interesting. And thank you a lot. Thanks for everyone who attended tonight. Thank you for WICCAM. And a special thank goes to ICOM company and the people behind the scene, Maysoon and everyone. So I should remind all of you that we have immediately after this webinar, another webinar will start maybe how many minutes from now? Yeah, at 7:30 London time. So around 45 minutes from now, we'll start the second webinar for the critical care advanced module, the last webinar. So anyone who is interested can register and join us for the transesophageal echo in ICU. Let's sum up. Again, thank you very much. Be prepared, as Dr. Haitham said, for the exam, which will start on September 16 for a week. And you're left with 3 weeks remaining, week number 21, 2, and 23. Thank you. Thank you, Haitham and Wissam. See
Thank
you.
you.
Bye.
Bye.
Thank you, Dr. Bushra. Bye-bye.